Our next presenter, and I'd like to call up to the lectern, is Christopher Hanna, and Christopher's the Community Health Manager at Tweed, Byron, in Northern New South Wales local health district, to tell us about My Aching Joints integrated services to rescue the osteoarthritic hip and knee. Christopher.
Thank you. Before I start, I'd like to acknowledge the traditional owners of the land in which we're meeting today, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present, and those that are emerging. I'd also like to acknowledge the Bundjalung people of northern New South Wales as the traditional owners of the land in which I live and I work, and the land in which this service was developed. I'd also like to give my thanks to the other members of the team who worked in this project, Dr. Jason Sung, orthopaedic surgeon, Dr. Brett Lynham, general practitioner and PHN representative, Evan Bryant, physiotherapist, and Luke Schultz, the project officer. Ladies and gentlemen, we had a problem. Not a unique problem. I'm sure we're not the only people here. I don't think we're that special. Our problem was that our demand for joint replacement surgery vastly outstripped our capacity to provide that surgery. And it was a problem that was only going to get worse. Our population is ageing and it's getting heavier. Osteoarthritis is a chronic disease. There's no cure for osteoarthritis. It doesn't get better. In fact, it's one of those chronic diseases that if you're lucky enough to live long enough, you'll probably end up having osteoarthritis. But there's a second layer of complexity to that problem. Nobody owned the problem. The patients, they had the pain, they had the problem, they had the osteoarthritis. The GPs were really important in providing the care, but neither of those people conducted joint replacement surgery. Our orthopaedic surgeons are all visiting medical officers. They subcontract their services to the hospital. They're happy to provide the surgery, but they don't control the waiting lists or the theatre times. Our local health district owns the hospital. It has the theatres and the waiting times, but it doesn't control, it's not the surgeons. The primary health network, very important in improving healthcare in the community through primary care, but again, doesn't provide the surgery. And the other factor that makes it really interesting in our situation is about 5 blocks north of my hospital is the Queensland-New South Wales border. We have New South Wales residents who see a Queensland GP to get their surgery in the New South Wales hospital. We've got Queensland residents who get their surgery in the New South Wales hospital. All our orthopaedic surgeons, their rooms are all in Queensland, if only by 100 metres. The only time the Queensland border really matters to us is during daylight savings and state of origin. So when you're faced like a problem like this, the only solution is to have a joint approach. Sorry for the bad pun. We did a co-design approach using the AIMS methodology, including the local health district, the primary health network, the GPs, and our orthopaedic surgeons. We also included patients in this process. We interviewed patients, we followed their journeys through the system, and we involved them in the design of the solutions. We decided we had 2 issues. One was an issue of communication. So Brett Lynham is our GP representative. His rooms are approximately 100 metres from the hospital. If he steps out his front door, looks to the left and cranes his neck a little bit, he can see the Tweed Hospital. To talk to the Tweed Hospital though, he has to send a fax to them. For those of you who are under the age of 35, don't know what a fax machine is, come and talk to me later, but trust me, in about 1983 it was cutting edge technology. It involves a phone line. Again, for those of you under the age of 35 who don't know what a phone line is, come and see me later. And yet, when Brett is communicating to his private pathology services, to the private radiology services, he has a secure electronic messaging services, medical objects, which carries that information, links to his medical record, provides the opportunities for two-way communication. In fact, Queensland Health have invested in medical objects as well. So when Brett sends a patient north to Robina Hospital, it's about 30 minutes away, Gold Coast University Hospital, 50 minutes away, Queensland Children's Hospital in Brisbane, an hour and a bit depending on the traffic on the M1, he can communicate through medical objects, linking to his EMR, getting responses. But he wants to talk to his local hospital, he had to use a fax machine. We decided to change that. For our arthritis service, we actually invested in using medical objects as well to improve communication. And you might think that that is a really, really simple thing, and why am I standing up here and telling you about that? But to the best of our knowledge, we are the first service in New South Wales Health to engage in that sort of an electronic messaging service with GPs. And the GPs absolutely love it. Secondly, we had a problem with the patient journey. So if you're a patient, you start developing some pain in your hip or your knee, it means that you can't walk as well as you'd like to. It impacts on your function. You can't play golf, you've difficulty getting up the stairs, difficulty getting off the low couch, whatever the problem is. And so you decide to go and see your GP. Now, I don't mean to disrespect any of the GP's clinical interventions here, but it seems that when you see your GP, they'll probably take an x-ray. They'll look at the x-ray and say, yes, there's osteoarthritis. They'll prescribe some painkillers, and they'll refer you to the orthopaedic surgeon for joint replacement surgery. If you're in the Tweed region, 10 months later, you'll actually see the orthopaedic surgeon, because that's how long it takes to get in as a public patient. They'll see you and they'll say, yes, you've got osteoarthritis, yes, you've got joint pain, yes, I can do joint replacement surgery, and they'll refer you through to the hospital. Well, there'll be a 12-month wait before you're actually contacted by the hospital to come to pre-admission clinic and then have your surgery a week or two later. When I look at that diagram there, it reminds me of the maps that you see in train stations off the train line. But trust me, the joint replacement train is not an express train. It's a long and slow journey of 2 years before you end up with major surgery. There has to be a better way. And we knew that there was. Because we know that if you're on the waiting list for joint replacement surgery and you engage in a program of exercise and self-management principles and weight loss, then you reduce your need for surgery. We also know that if you do go on and have surgery, you get better, faster, you get better outcomes if you've been through a program like this before you have the surgery. But that led us to ask the question, why wait on the waiting list for surgery? There's a 10-month delay there before you even get to the surgeon. So we created a service, the knee and hip arthritis service, to give the GPs another option in care. So rather than just referring to the surgeon, they could refer directly to our service. They could cover both bases and refer to the service and to the orthopaedic surgeon. Or if they referred to the orthopaedic surgeons actually had their rooms set up to refer the patients directly to us without even waiting for them to be seen by the surgeons. It's a physiotherapy-led clinic. It is run through the LHD. It was initially funded in the pilot through the PHN. It provides a comprehensive assessment. Being physios, they obviously do exercise training, but also training in self-management, and particularly around the concepts of chronic pain management, and also refer to other services as necessary, dietetics, counselling, so forth. This means we've built the service around the patient, hopefully to communicating well and protect them. And some people, yes, they still require joint replacement surgery, but we hope it is now the road less travelled. The question is, does it work? Well, we've now had 400 patients through the clinic, and these results are early results, but we've seen the trends continue as we've got more and more data. 3/4 of patients go from having a moderate to severe functional disability to a mild to moderate. 70% reduce their pain from moderate to severe to mild to moderate. 2/3 rate that the walking has improved. 80% say the day-to-day activities have improved. 2/3 say that the hips or knees have improved in general. These are good results. If it was my hip and my knee, I'd take those. But the last line here is the killer. 6 to 18 months later, 80% of people weren't on the waiting list for surgery and didn't want to be on the waiting list for surgery. They were looking like they're going to avoid having surgery. There's another really good result as well that isn't on this slide, and that is that the orthopaedic surgeons tell me that now when they get a phone call from the physio in the clinic saying, I've got somebody here and I think they really need to see you, they get them in straight away because they know that that person really needs to see them. This is providing the right care for the right person at the right time. But don't just take my word for it. Let's hear from some other people.
Leading better value care is about the patient as part of the decision-making process and to inform them on the problem, what can be done to help, supporting the patient to more effectively manage their osteoarthritis.
The spectrum from early disease to late disease, there is this whole area in the middle which is not managed in a very consistent manner. And so we certainly saw a need and value in trying to produce a service to give patients the ability to access good, consistent care to get optimum function, and all of a sudden you get a patient who's got a painful minor arthritic knee to a painless minor arthritic knee. So in terms of the arthritis, that hasn't changed, but their function is dramatically improved.
I was quite enthusiastic from the outset for several reasons. One is obviously I could see the patient benefit and the clinical benefit to patients, but also the integrated care really appeals to me, the idea of actually GPs and the primary health network and the LHD and specialists and hospitals actually working together to get a result and communicating with each other. It's undoubtedly the way that medicine should be moving to.
In the past, management of these issues has been mostly symptomatic. Often would only try pain relief, and if that didn't work, then possibly referral to an orthopaedic surgeon to discuss joint replacement surgery. But we now know there's a lot of other options without going down the line of joint replacement surgery too soon, or without giving other options a trial first.
We started this program as a pilot, trying to really identify, well, is this something that we can improve in this space, become both an effective service that will provide a lot of value for the community, as well as minimise specialist intervention in earlier phase, but it really wasn't required.
Sometimes communication is the best way to get simple changes like this, simple but effective changes across the line.
Well, I've had problems with the knees for many years. I'm not able to walk really well, and I was also taking a fair bit of medication for the pain. I refused to have an operation, and I wanted to be able to stay in my own home. So we had to look for other options, and this seemed like a good one.
Everything was sort of getting worse. Then I started falling, or my knees would give way. That was horrifying, because until you've lost confidence in something you take for granted, like walking, you don't know how inhibitive that can be. And now I don't need walking sticks. I am confident, but my legs are doing the work.
Of the patients that have been through the program so far, 2 out of 3 have reported that their pain has improved, or their knee or hip function to have improved, and 2 out of 3 have reported that their walking has improved.
Anecdotally from my patients, I'd say at least probably 3 out of 5 of my patients have avoided or declined surgery, gone away from the surgery path.
I have so much to thank the program for. How do you say thank you when something's given you your freedom, your confidence, your life back?
Thank you. So where's the future heading for us? We're rolling out these clinics across the whole of the Northern New South Wales Local Health District. We are keen to see that every client at least has an assessment in the clinic before undergoing surgery. The next stage that we're looking to implement as well is to say that because we know the issue that weight has on osteoarthritis and the difficulties of rehabilitation following a knee replacement, that no client with a BMI of greater than 40 should undergo a knee replacement without having a secondary review of their situation. So what can we learn from this? The first learning is that we didn't have a complex problem. Rather, we had a problem of complexity. And in that situation, a simple solution is often the best. And secondly, when we're faced with the challenges of integrated care, and we're hearing about that over these days, that they seem enormous, they're overwhelming. But if we act within our own sphere of influence, then we make things better for our patients. Thank you.
It is? Okay. Thanks so much, Chris. If that's not if you're not the poster boy for integration at this conference, I don't know who is. What an amazing program and amazing results. We do have time for a couple of questions now. Here. And as I said, please use the microphone so the people who are live streaming can hear.
Hello. Can you make some comments about how consumers responded to the behavioural health aspect of the program in terms of lifestyle modification, because there would have been a need for quite an active participation on their part?
Ultimately, they've responded really positively to that. And I think that comes through having a physiotherapist do it. I'm a physio by background, so clearly we're amazing. But because there's a physical thing that you're doing with someone in terms of exercising, and that they can see the results, we're exercising on the knee joint and the knee's the problem, there's a direct link there that then provides a buy-in to the other interventions, such as weight loss and so forth.
I've heard from other physios that they, do advise lots of, exercise, but they don't get the buy-in. So is there something operating here?
Possibly also the fact that the clinic is reinforced by the GPs and by the surgeons. That gives it the authority.
Got time for one more quick question up here.
Thank you. My name is Ahmed bin Nasser. I'm an orthopedic surgeon, a joint replacement surgeon from Saudi Arabia. And I'd like to congratulate you for success in your project. But it seems like I just have a couple of questions, which is number one, the indication for surgery is usually failure of conservative therapy, and all clinical practice guidelines, international clinical practice guidelines when it comes to joint replacement usually follows physiotherapy. Have you tried doing combined clinics where the orthopedic surgeon, dietitian, physiotherapist, being all, the decision maker is, the decision is made where the patient is sitting along with everyone involved, including sometimes if the patient is diabetic, a diabetologist, and so on. All other specialties have a sit down and discuss with the patient?
The short answer to that is no, that we haven't tried that as yet. Currently, orthopedic surgeons are visiting medical officers. They have their own private rooms elsewhere where they see the clients rather than having clinics within the health system. And so that's a next step that we could be looking at taking. Thank you.